بسم الله. السلام عليكم.
دكتور فهد،
ايوه
كيف حالك؟ اخبارك؟ انا غالب معاك.
ايوه غالب،
كيف حالك؟ اخبارك؟
الله يجزاك خير، حياك الله.
الله يكرمك. اخبارك؟
انا ما ادري احنا ان ولا اوت ولا وش القصه.
بتقول لي ايش؟
لا احنا اذا let us end to start ولا وين يعني to start؟
لا لسه هيالي بقى. انا عندي مشكله، فهم قالوا لي هيدخلوني ساعه المحاضره.
when I'm supposed to start now?
731.
دكتور محارب، كيفك؟
اهلين.
كيف احوالك؟ رياض معك.
ايوه ما انا your I recognize your voice I guess.
ابو فهد
Now
مشغل
they will
انا اشوف داخل انت باسمين يعني ولا ايش؟
ها؟
انت مشغل الكاميرا ولا اشوف داخل باسمين؟
والله I don't know, I entered once.
طيب.
بس الحين how can I enlarge الفيو؟
صح، في فول سكرين على بالازرق.
ايوه I did the full screen. I now I am full screen according to myself.
السلام عليكم، كيف الحال دكتور فهد؟ معك مهند.
أهلين مهند.
لا أنا شلون صحتك؟
Good. You'll be with I'll give just introduction, then I'll hand it to you and أحلام.
أوكي.
فراس. فراس.
السلام عليكم.
عليكم السلام ورحمة الله.
طيب طبعا we are having now more than 2000 attendees.
كيف عرفت فراس؟
And I ask the technical team, the number is not showing in front of you. They will hopefully will fix it. يعني, either later on when we go live or hope for sure tomorrow. But we have more than 2,000 now are with us and we are live now. So we'll wait maybe a minute and then we'll start.
Hey, Firas?
سمعتني يا ابو فيصل؟
So when no, I didn't hear the last part.
يعني in 1 minute you can start. يعني we have now a number we have now 3,000.
دكتور فراس.
تفضل.
دكتور فراس، انا دكتور غالي معاك. انا بعد اذنك انا كنت جربت معاهم الظهريه النهارده، كان عندي مشكله ان هم قالوا لي لازم هم اللي يعرضوا لي البرزنتيشن من عندكم، فبس بلغ حد فيهم انا اوريدي معاكم.
اي لا عندهم خبر.
عندهم خبر يعني؟ اوكي خلاص.
ايوه توني حكيت محمد عارف هو.
طيب خلاص اوكي.
طيب ابو فيصل let's start please.
بسم الله الرحمن الرحيم. بسم الله والحمد لله والصلاة والسلام على رسول الله. I am Fahad Al-Muharib, a member of the Hematology Department at King Faisal Specialist Hospital and Research Center, Riyadh. As you noticed, I met Dr. Chaudhary, who was supposed to be here, but he could not make it today. And it wasn't announced, I think, because from the organizer, hopefully not to lose the high attendance number, which is around 25,000. MashaAllah, la quwwata illa billah. So on behalf of SSBD, the Saudi Society of Blood Disorders, it is my privilege and a great pleasure to welcome all of you and officially open the first day of the annual Saudi Hematology Congress 2021 virtual meeting. The Congress will last for 7 days, and as we were doing in the last few years, we start with the Saudi Hematology Research Day. We will have short presentations of selected abstract, followed by 20 minutes poster display, then awarding ceremony of abstract winners and sponsors e-recognition. And at 9:50 p.m., we are honored to have Professor John Begrebin, who is current president of EHA, for AbbVie Satellite Symposium, speaking in refractory relapsing CLL. Before we start, I would like to thank all the participants, speakers, moderators, and attendees. And hopefully, in the future, we could have more participation from our colleagues as we have in pharmacy, nursing, pediatric hematology, and hematopathology. Also, we should not forget thank the sponsors of the Congress for their generous support. And please don't forget to visit exhibition often. And of course, the great support from our audio, or great technical support from our audio visual company. And please don't. You could ask question by going to go to sessions and tab the platform and then click on ask question tab. Now I'll hand the podium to our colleagues, Dr. Ahlam Mas'ari from King Faisal Specialist Hospital and Research Center in Jeddah, and Dr. Muhannad Al-Hamid from King Saud Medical City in Riyadh to moderate the research presentations. Thank you again, and we hope to have a fruitful annual Saudi Hematology Congress 2021 virtual Congress. Thanks.
Muhannad, you are mute.
Assalamu alaikum. معكم مهند حميد. Hi, I would like to welcome everyone again and thank the organizing committee for the invitation. I want to remind you that every speaker has 8 minutes to finish his presentation. And the second reminder after 6 minutes will be announced as well. I'll leave the first, Dr. Amal Al-Masari. Dr. Amal?
طيب. Dr. Muhannad, you can proceed, please.
So our first presenter, Dr. Riyad Al-Faqih, with the presentation titled Clinical Course and Outcome of COVID-19 in Hematopoietic Stem Cell Transplant Patient, original report from the Middle East. Dr. Riyad Al-Faqih is working as a consultant in hematology, stem cell transplant and cellular therapy, and head of the clinical research department at King Faisal Specialist Hospital and Research Center in Riyadh. He's associate professor of medicine at Al Faisal University. Dr. Riyad.
Thank you, Dr. Muhannad. So can we have the slides, or should I share from my end? Can you hear me, Muhannad?
Yes, I can hear you.
The technical team will share the slide, Riyad, or list it.
So actually, I can start awaiting the slides. Basically, but as you know, COVID is a deadly illness, potentially in some patients, and specifically in cancer patients. And several studies have shown that cancer patients are at a higher risk of morbidity and mortality. So what we've done, we looked at the transplant patients who developed COVID post-transplant, trying to understand the outcome in these patients. So we reached out to the Gulf countries and we collected 91 patients from the Gulf area from 10 centers. So 91 patients were collected, and here we report the outcomes of these patients post-COVID infection. So I hope you can see my slides, and I'm trying to move the slides.
Clear, Riyad. Thank you.
Okay. Can we move the slide, please? Second slide. Lisa, can we move the slides? Or should I share my screen?
Hey, give us 1 minute, Riyad.
Okay.
Riyadh, can you try to share from your side?
Sure.
Can I take it to share from my side, please? Please, thank you. I'll take
You
the
will
screen
share from
my
your side?
Yes, please.
Okay.
Yes, can you see it?
It's loading. I cannot see my slides.
All right. Does it still loading?
Yes.
Yes, yes. Yes, this one. So is this known as a slide?
Yes, clear now.
All right, good. Fine.
Riyadh?
Unfortunately, I cannot see the slides from my end, so I'll ask you to move through the slides, okay, if that's okay. So let's move to the third slide. So basically, as I told you, COVID is potentially lethal infection, and especially in patients with cancer. And what we did is trying to study the outcome of patients who had a transplant and developed COVID post-transplant. So it's a retrospective study from 10 transplants across the Middle East. And what we did, we studied the outcomes of these 91 patients who had COVID post-transplant, and the outcomes in terms of how many needed hospital admission and what was their WHO COVID severity stage. And we made a severity composite endpoint, which was consistent of admission to the ICU, the need for oxygen, need for mechanical ventilation, and mortality. So it's a composite endpoint, okay? So three main endpoints: hospital admission, WHO severity, and the composite endpoint. And we studied the impact of different risk factors on these endpoints, and these risk factors that were studied about the correlation with the endpoints were the age, sex, body mass index, presence of comorbidities, type and number of transplant, type and intensity of conditioning, being on immunosuppression, the current status of the underlying disease, the use of prophylactic antimicrobials, and the time from transplant to COVID infection. So again, 91 patients, and the pre-infection characteristics were as follows. The median age was 35. 73% were thin with a BMI less than 30, and 52% did not have comorbidities, okay? Only 16% had multiple comorbidities. The underlying diseases before transplant were 23% benign, 30% leukemia, 29% lymphoma, 18% multiple myeloma. 57% were allotransplanted, 43% were autotransplanted. 89% received myeloablative conditioning, so the majority, and 77% of the conditioning were non-TBI, okay? The median time from transplant to catching the infection was 14.9 months, okay? And 46% of the patients were not on immunosuppression when they catch the infection, okay? So first of all, let me tell you the clinical outcome of these patients. 86% had symptoms, 14% were asymptomatic. The symptoms were pretty much like any viral illness: fever, cough, and shortness of breath. These are the most frequent symptoms. 58% of the infected patients had abnormal chest X-ray, and 13% had elevated white count. 3% had elevated lymphocyte count. 52% had reduced lymphocyte count. This is when they were admitted with the infection. The neutrophil count was high in 13% of the patient. Platelets were low in 45%. Ferritin was high in 67% of the patients. Sedimentation rate was high in 75%, CRP in 87%, and the albumin was low in 77% of these patients. The outcomes. So 50% of these 91 patients had mild COVID-19 stage per the WHO staging criteria. 53% were admitted to the hospital. 14% needed ICU admission. 10% needed mechanical ventilation. 18% needed oxygen. 4 patients died, constituting 4.4% of the total population. Okay. Of these patients, we had follow-up swabs, nasopharyngeal swabs, and 77% of them cleared the infection at a median time of 34 days. And of these patients also, we had follow-up antibody testing, and 67% of the tested patient tested positive. So we're able to mount antiviral antibodies. Acute kidney injury happened in 10%, was reversible. Thrombosis was only in 1 patient, and it was line associated. So as far as the correlation of the risk factors with these outcomes, the time from transplant to COVID infection, more than 6 months. So patients who were transplanted more than 6 months, and then they catch the infection, had a lower admission rate of 74% as compared to 45% to the others, okay? And had a lower rate of severity composite endpoint, 35% versus 16%. Okay, patients who were not on prophylactic antibiotics, okay, before the infection, had higher admission rate. For the subgroup of the admitted patient, high neutrophil count was associated with higher need of mechanical ventilation, and males required more ICU admission. And again, 2/3 of the patients were able to mount an antibody response, and 77% cleared the infection by PCR testing. So we report favorable outcome of our patient, okay? Our mortality was only 4.4%, okay? And our interpretation is that our population had a younger age and less comorbidities as compared to the reported cohort from the West. All our patients were treated in tertiary care centers, while the patients reported from the West were in different centers because the healthcare system was overwhelmed. And in line with other reports, we show that the mortality in transplant patients is lower than patients with hematologic malignancy and lower than patients with solid organ transplant. And our interpretation was patients who undergo transplant are selected. Okay, so this is positive selection of fit and young patients. And the other thing is the theoretical lower intensity of lung inflammation from an impaired immune system in the post-transplant. So lung inflammation was less in these patients, and as such, the mortality was lower. I'd like to thank the patients and the families, the SSBD for the administrative support, and all the colleagues who shared their patients and their patients' outcome across the Middle East. With that, I will finish, and thank you so much.
Thank you, Dr. Riyad, for this great paper. I would like to welcome all the audience. We have 6,500 attendees. This number is the only feasible number to the technical as of now. Hopefully, they will be fixed, inshallah, tomorrow. I want just to emphasize that each speaker should go with a 6 to 8 minute talk only, because if we finish on time, we'll be able to take 1 to 2 questions for discussion. So I would like to encourage all audience to post their question in the chat box, please. Now it's my pleasure to introduce the second presenter, Dr. Hadil Al-Haddad. Dr. Hadil is Internal Medicine Senior Registrar. She did her residency in Dr. Sulaiman Faqih Hospital. She did her fellowship in National Guard Hospital, Jeddah. And she just passed the final written and clinical adult hematology fellowship exam. Her paper title is Transfusion-Dependent Anemia and Cytopenia Secondary to Parvovirus B19 Infection as the First Manifestation of X-linked hyper-IgM immunodeficiency syndrome in 2 male patients in their third decade of life. Dr. Hadeel, floor is yours.
Thank you, Dr. Ahlam, for the introduction. Good evening, everyone. It's my pleasure to be talking today about my topic, which is mentioned by Dr. Ahlam. Next slide, please. We describe primary patients with unique mutation of CD40 ligand gene, unlike a classic presentation of X-linked hyper-IgM immunodeficiency syndrome. Both were healthy until presenting in their early 20s with a challenging symptomatic transfusion-dependent anemia. Investigations confirmed X-linked hyper-IgM syndrome with concurrent chronic parvovirus infection. Hyper-IgM syndrome, next please. Hyper-IgM syndromes are a rare heterogeneous group of primary immunodeficiency disorders characterized by defects of immunoglobulin plus switch recombination with or without defects of somatic hypermutation with impairment of NK and T cell cytotoxicity. This leads to low levels of IgG, IgA, and IgE with normal or elevated levels of IgM and poor antibody function. Hyper-IgM syndromes are genetically determined and are further subdivided into 5 subgroups based on the affected gene. Okay, next. The most common form is X-linked hyper-IgM, which is inherited in an X-linked manner, constitutes around 70% of cases, with an estimated prevalence of 1 per 1 million males. The disease-causing gene is CD40 ligand, located on the long arm of chromosome X. The combined T and B immunological defect is clearly illustrated by the susceptibility of patients to recurrent infections, autoimmune disorders, and malignancies. Half of the males develop symptoms by year 1 of age, and by year 4 of age, more than 90% are symptomatic. Clinical manifestations include infections, liver manifestations, malignancies, and autoimmune disorders, as well as hematological manifestations such as anemia. Next. Clinical manifestations of parvovirus varies depend on the immunological status of the affected host. In children with intact immune system, it's considered a common self-limited and usually causes a mild febrile illness, while in adults it may cause arthritis. On the other hand, when immunocompromised patients get exposed, their immune system is unable to produce neutralizing antibodies, and viremia persists and might cause aplastic anemia and RBC aplasia. Next. Rarely, certain CD40 ligand mutations can result in mild phenotypes of X-linked hyper-IgM. These patients remain asymptomatic and undiagnosed, with the disease manifesting only after exposure to parvovirus B19 infection, just like our patients. Case 1 is a 20-year-old male who had completely normal childhood with no recurrent infections, presented with intermittent transfusion-dependent anemia of unknown cause, despite extensive investigations over 6 years. He had cyclic episodes of fever of unknown origin, weight loss, and night sweating, accompanied by drop in hemoglobin with hepatosplenomegaly. Despite relatively prolonged periods of spontaneous remissions for almost 3 years, the patient relapsed and became progressively transfusion dependent, needing transfusion almost every 2 to 3 weeks with thrombocytopenia and neutropenia. His initial bone marrow biopsy only showed evidence of an effective erythropoiesis. A repeat bone marrow biopsy showed erythroid hyperplasia with maturation arrest and features consistent with parvovirus B19 infection, as illustrated in this figure. The first figure and the second one are bone marrow aspirate showing the viral inclusions, and here the bone marrow biopsy showing also the viral inclusion. In view of the bone marrow biopsy findings, parvovirus PCR was sent and it detected parvovirus genetic material. Because it's very unlikely for parvovirus B19 to cause such a picture in immunocompetent patient, the infection with parvovirus raised the possibility of an immunodeficiency syndrome and led us to perform whole exome sequencing, the result of which revealed the presence of mutation in the CD40. Immunoglobulin levels were checked, and he had mildly elevated IgM, slightly low IgG, and normal IgA. He was born of a consanguineous marriage. His mother was negative for the same mutation with negative family history, with negative maternal family history of similar condition, making his diagnosis as de novo X-linked hyper-IgM. The patient was treated with IVIG course for 3 days, followed by monthly infusions. And shortly after the infusions, he had a tremendous response in his CBC and complete normalization of symptoms. This table showing his hemoglobin of 5 before treatment improved to 16 after treatment. And this is the result of the parvovirus B19 serology and PCR. And here the result of the whole exome sequencing showing the mutation of CD40 ligand, its variant and its type and the classification. Next. Case 2 is a 22-year-old male who had also completely normal childhood with history of recurrent mild sinusitis and ear infections, presented with symptomatic anemia. His hemoglobin has fallen to the low levels of 4.8 and neutropenia. He had hepatosplenomegaly. Investigations ruled out hemolysis. He had severe reticulocytopenia and viral serology was positive for parvovirus B19 IgM. Bone marrow examination showed similar features to case 1, and based on our previous experience with the first patient, which raised the suspicion of immunodeficiency syndromes, whole exome sequencing was sent.
Dr. Hadid, you are muted now.
Sorry. Okay. Case 2 is a 22-year-old male who also had completely normal childhood with history of recurrent mild sinusitis and ear infections, presented with symptomatic anemia. His hemoglobin has fallen to low levels of 4.8 and neutropenia with hepatosplenomegaly. Investigations showed parvovirus B19 IgM. Bone marrow examination showed similar features to case 1, and based on our previous experience with the first patient, which raised the suspicion of immunodeficiency syndrome, whole exome sequencing was sent and showed CD40 ligand gene mutation. Immunoglobulin levels showed mild elevation of IgM with low IgG and very low IgA. The patient required 4 months transfusion, and it took him around 30 days to become transfusion independent and another 60 days before normalization of his hemoglobin. Patient was born of a consanguineous marriage, and family members testing is currently being conducted. This table showing his investigations and hemoglobin of 4.8 at baseline improved to 13.3 after transfusion. And here is the result of parvovirus and the whole exome sequencing showing the mutation of CD40 ligand with its type and classification. In the early years of life, usually with different presentations, mainly infectious. Here we are reporting 2 unique patients with a rare presentation in regards to the age of presentation and to the presentation itself, as both presented with chronic anemia induced by parvovirus B19 infection, manifested after the age of 20 years. There hasn't been in the literature a clear association between specific mutations and the clinical phenotype of the patients. In a retrospective analysis of 98 patients with X-linked hyper-Rgm syndrome, only 6 had mild clinical phenotype. 3 out of the 6 patients presented with parvovirus B19-induced anemia. These 3 patients were completely asymptomatic until they developed chronic anemia caused by parvovirus infection at the ages of 8, 14, and 17 respectively, and all the 3 patients responded well to IVIG. One of the 3 mild phenotype presenting with parvovirus infection-induced anemia had the same mutation expressed by case 2, which is a missense mutation, while case 1 had a stop-gain mutation, which is a very rare variant that has not been published yet in any of the genetic databases, and classified as likely pathogenic based on the American College of Medical Genetics recommendations. This table showing all the published cases with X-linked hyper-IgM and parvovirus B19-induced anemia in adolescent and young adults, and they were all published in one paper by Tca. In conclusion, In conclusion, we are reporting 2 cases of late presentation of X-linked hyper-IgM. The similarity between the 2 cases is the occurrence of protracted anemia requiring blood transfusion from an unexpected, relatively benign virus. The other point of similarity is their relatively late presentation, probably indicating a milder form of disease from these 2 reported mutations. The occurrence of such a clinical scenario ought to raise a high index of suspicion of an underlying immunological disorder. We believe in the era of easily accessible molecular diagnostics, and more undiagnosed cases will come to light with heightened awareness of this condition. Thank you.
Thank you, Dr. Hadil. I would like to encourage all audience again to post their question in the chat box, please. Our third presenter is Dr. Badr Al-Lahyani. Dr. Badr completed the Canadian Pediatric Hematology and Oncology Fellowship. He's a pediatric hematology oncology staff at King Abdulaziz Hospital with research focus in pediatric thrombosis. His paper title is The Current Practice of Management of Asymptomatic Central Venous Catheter-Associated Venous Thromboembolism in Children, a result of Saudi Arabian Pediatric Hematology Oncology Society survey. Dr. Badr, the floor is yours.
شكرا دكتورة أحلام. I already shared my slide. I don't know if you have it. Hello. Assalamu alaikum.
Professor, do you need to share your slides or share by our side?
لا I'll share it. Okay, can you go in?
Yes, please.
Okay. Thank you for opportunity to present on behalf of SAFOS this project. At best, we can call it controversy. So we're presenting our data from a survey. We asked about the current practice of management of asymptomatic central vein thrombosis associated clot in children. So looking to the incidence in pediatric, this is the histogram from early 90s by the Canadian group, which shows the bimodal incidence high in infancy and neonatal period, and then come down, going up again, and continuous from the teenager and to the adulthood. And after that, the American did the studies, few studies, and then lately the Scandinavian, which we published in 2018, that increase in incidence 2 to 3-fold in pediatric thrombosis, and likely related to advanced medical intervention. And the big elephant in the room is the central vein catheter. The incidence in pediatric between especially in the critical care, between 7 to 35, and the majority of them is asymptomatic, going about 22%. So if we look to the current available evidence for the management of asymptomatic venous thrombosis related to a line CHIST guideline 2012 was recommending treating any provoked asymptomatic clot for 12 weeks. And this sounds very aggressive nowadays. And after that, the British 2018 published a guideline which the phrasing and the language is different a little bit, and they're saying it's reasonable to withhold the anticoagulation and just wait and see and monitor the patient if later you would initiate the anticoagulation. And late 18, early 19, ASH guideline came up with a different recommendation that suggests either you treat or not with anticoagulation for patients with asymptomatic clot. And here we see how confident we were at 2012, and we were thinking we know what we are doing, and nowadays we are more aware that we're not really sure what we are doing with this type of presentation and complication of the intervention. And worth saying, GIST group is the same to the ASH group, so the same people change the platform. What would trigger us in my fellowship, I did a systematic review looking to the asymptomatic clot in pediatric and neonate, and we published it and we presented at ASH. And this year it's recently accepted for peer review, so hopefully we'll see it soon. But during our review and search, we from 800 paper, we found only one Saudi study. So it was really surprising. We have only one study. So I was really curious, are we seeing this type of clot and how we manage it? So I contacted the people at SAFOS, and they were very welcoming, and they helped me to address this question. So we did a case-based survey and to assess the local management strategy for pediatric asymptomatic CVC-related clot, and we looked to the four elements. First, the use of thrombophilia testing, inherited thrombophilia, and how would people approaching this type of clot? Are they observing or just treating with anticoagulation? And for how long if they would treat, and the use of secondary prophylaxis. For example, if this patient required another CVC. So we had really good response rate as at our target. We were really surprised. It's 30%, and we see like a variety of people, and the majority were treating like hematology and oncology pediatric patient. And the population was very heterogeneous, and we were happy about that, fellow and like junior faculty and expert as well. And the figure is very important, and we see almost 60% seeing 1 to 10 patients, but 40% of the people is seeing more than 10, which is a really high number. So we are seeing this complication, and it sounds common in our population as well. So the case was hypothetical, and it's a 4-year-old female, unlucky, got admitted to ICU for a septic shock and infection, and incidentally they did ultrasound after placing the line after a few days, and incidentally they found a clot, and so it's called asymptomatic central line related clot. So we asked the people initially, would you treat this would you test for inherited thrombophilia? And not surprisingly, like the majority say no, we wouldn't, which is match the recommendation from all the guideline and the recent choosing wisely. So then we ask how would you manage and approach this patient, and 95% they would treat with anticoagulation this type of clot, and this match the recommendation, if you remember, from CHEST guideline 2019. And of them, 20% they said they would only treat if there is a propagation in the follow-up, and we found like a wide variability in the duration. It was all over the places, from 6 to 12 weeks, or people said we would stop anticoagulation after the central line remover. So we asked a question: what if this unlucky girl would require a central venous catheter again? And it's not uncommon scenario that we see people getting admitted to the ICU 2-3 times in 1 to 2 years, especially patients with chronic severe illnesses or malignancy.
1 minute.
Sure. So so we asked about secondary prophylaxis. Would you do secondary prophylaxis for this girl? And 20% only said yes, we would do. And interestingly, 20% said they would do only if she had a positive inherited thrombophilia. And it was very interesting that people guided their secondary prophylaxis by the thrombophilia workup. And the majority said they wouldn't start. So we know it's a small sample. Regardless, I'm not presenting the whole community treating ICU people is treating an adult as well, treating this if they don't have the service, and it's a hypothetical scenario. People may change their practice in the real life. And in conclusion, it's the first study or survey touched this subject, and it's a common identity. We see it with limited data regarding management, and we see a variability in the clinical management, and it's a common, as we see 40% saying more than 10 per year. So we hope we can get all together, share our experience, and come with the good evidence supporting our practice. Thank you for my team, the audience, and all the members, SAFOS member involved in the survey. Thank you for opportunity, everyone.
Thank you, Dr. Badr. I would like to welcome the audience. Just joined us. We reached up to 7,000 attendees. So welcome all in the 6th Saudi Hematology Research Day. The fourth speaker will be Dr. Faisal Al-Jaber. Dr. Faisal is a senior medical student at King Faisal University in Al-Hassa. He has completed the UCMLE Part 1 exam in August. He is motivated to learn, grow in obtaining knowledge for improving medical diagnostic skills. His paper title is Splenectomy Perspective for Hematological Disorder, a cross-sectional study from the Eastern Province of Saudi Arabia. Dr. Faisal, floor is yours.
Yes, I hope the voice is clear.
Yes, it is.
Okay. Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone, and hello. My name is Faisal Al-Jaber, a final year medical student at King Faisal University. Today, inshallah, I'm going to be presenting a research that we have been working on, my colleagues and I, during the last year, which is titled as the Splenectomy Perspective for Hematological Disorders, a cross-sectional study from the Eastern Province of Saudi Arabia. Okay, next.
Can you move Dr. Faisal the slide from your side?
I'm trying.
Okay, other option, we can ask technical to share. Ayman, please.
Okay, it would be better. Okay, I hope it is clear. Okay, so as like an introduction, as we know that the spleen is considered as one of the secondary immune system organs, in which it is very important to protect our body. Like with splenic macrophages, it protects our body against several encapsulated organisms, for example, Streptococcus pneumoniae, Haemophilus influenza, meningococci, and so on. And also the spleen is very important in order to clear our body from the old RBCs. At the same time, like in Saudi Arabia, there are certain hematological disorders that are prevalent. For example, as we can see on the left diagram, it shows the distribution of the sickle cell disease among the different regions in Saudi Arabia. For example, in the eastern region, like in 2015, it shows around 130 births per 1,000 as the prevalence of the sickle cell disease. On the right diagram, it shows the distribution of the thalassemia among the different regions of Saudi Arabia. Let us look at the same time to the eastern region. At 2015, it shows 20 births per 1,000. So certain hematological disorders are actually very prevalent in Saudi Arabia. And like with certain hematological indications, the spleen needs to be removed in a procedure which is the splenectomy. Like for example, splenomegaly, hypersplenism, or like autosplenectomy in splenic atrophy with sickle cell disease. And although like the splenectomy is considered as a therapeutic procedure, still it has like several complications for individuals that might develop it after the operation. For example, they are going to be more prone for the infections, so they need regular vaccinations and regular antibiotics, like pre and post operatively. Also, they are at risk of like vascular complications, like post splenectomy thrombocytosis and so on. And patients need to be properly educated whenever they develop like fever or any complications, and they should come to the hospital immediately. With that being said, like proper education of patients by the healthcare physicians as well as like hematologists about the importance of recognizing early manifestations of complications, as well as being compliant with medications and vaccinations, actually of utmost importance. To our knowledge, no previous studies in Saudi Arabia like have demonstrated this issue. Next slide, please. Yes, so the objective of this study is to gauge the holistic overview and the current practice of the post-splenectomy preventive measures among patients from the Eastern Province with the different hematological disorders. So to fulfill our objective, we have like the methodology. We have obtained the consent from the IRB and the Research Ethics Committee from King Faisal University, and the informed consent was obtained from all of the participants. And we wanted to go to the field and being on site with the individuals and with the patients, but because of the pandemic, we were not able to do that. So we had to distribute the questionnaire online through WhatsApp and Telegram, and we go to the society groups, like hematological society groups with individuals who have done a splenectomy, and we have targeted them specifically. And we have obtained the data and analyzed it through the SPSS version 21. Next slide, please. So as for the result, 179 patients in whom they were diagnosed with different hematological disorders, we have obtained a response rate of being 21.2%, and 38 patients have filled the questionnaire. And as you can see, on the table 2, it shows some of the biographical data, and it shows the age of the individuals who have done splenectomy. Individuals who 14 patients have done the splenectomy when they are less than 18 years of age, 11 patients between 18 and 29, 11 patients between 30 and 39, and 2 patients between 40 and 49. And all of the patients, they have removed the spleen completely, and 28 patients have done it open splenectomy. And 28 patients also have done the elective procedure, and they have been discussed about the procedure. As you can see on the right table, it shows the patients and the number of patients who actually have regular vaccinations preoperatively were 20 patients did not receive the vaccinations, and 17 patients also did not receive the vaccinations post-operatively. And the number of patients were told to come to the hospital immediately whenever they develop fever were 21, and 17 patients were not informed about this. And also the number of participants or patients who received antibiotics post-operatively were 31, and 7 patients did not receive antibiotics regularly. And this put a high a mark to this point. So the prevalence of patients who were also reported being or getting better was 94.7%, in which there were 26.3% of patients were reported to have an interval of more than a year between splenectomy and the recurrence of the disease. So they have recurrence of the disease, and not all of them they got better after the operation. Next slide, please. So as for the conclusion, although most patients were improved following the operation, it was only for a short period of time, and lack of education as well as proper practice for the post-splenectomy preventive measures were not highly achieved actually. Hematologists as well as primary health care physicians must pay more attention to inform patients about the importance and provide them with the proper post-operative preventive measures. This was our conclusion, and we like to gratefully acknowledge Professor Dr. Osama Zakaria from our college for his support and help. And these are some of the references. And thank you very much.
Thank you, Dr. Faisal. I would like to encourage all audience again to post their question in the chat box. Our fifth speaker, Dr. Ghalib Al-Yamani. Dr. Ghalib is a consultant in hematopathology and blood bank at Prince Sultan Military Medical City in Riyadh. He is also clinical assistant professor at King Saud University and associate professor at Research Institute in Egypt. His paper title is High Expression of WNET beta-catenin inhibitor in plasmablastic lymphoma compared to diffuse large B-cell lymphoma may identify potential therapeutic target. Dr. Ghalib, the floor is yours.
Thank you, Dr. Ahlam, for nice introduction, and thank you for the scientific committee for selecting my abstract for oral presentation. So, my presentation, please. Good. So this is my presentation, as Dr. Ahlam mentioned, high expression of YNT beta-catenin inhibitor in plasmablastic lymphoma compared to diffuse large B-cell lymphoma may identify potential therapeutic. Next, please. YNT beta-catenin signaling pathway, also called YNT pathway, facilitated cancer stem cells renewal, cell proliferation and differentiation, apoptosis and migration and invasion, thus exerting crucial role in tumorigenesis and therapy response. Increasing evidence indicates that this regulation of this pathway contribute to the development and progression of some of solid tumor and hematologic malignancy. Accumulated investigation highlights the therapeutic potential agent targeting YNT pathway in cancer. Next, please. Next, please. So this is the last review article published 2020 discussing details this targeting of this pathway in cancer. Next, please. Okay, this is also the clinical trial and the preclinical evaluation of this pathway targeting agent in hematologic malignancy. If you look, the cancer type is all are concerned with AML or ALL or CML or multiple myeloma. However, there is no plasmablastic lymphoma or more aggressive tumor except beta lymphoma. Next, please. Next. So this is also some targeting agent in the therapy, which the last one is DDK1 monoclonal antibody discovered in the market 2020. Next one, please. Also, this pathway is assessed in multiple myeloma and approved to be a half advancement in multiple myeloma and resistant to the therapy. And currently there is a target therapy for this regulated YNT pathway as adjuvant treatment in multiple myeloma with beneficial result. Next, please. Next. The role of this pathway in aggressive B-cell lymphoma is emerging. In a diffuse large B-cell lymphoma, modulation of this signaling pathway reported linked with poor prognosis through its expression of FOXP1. Next, please. Plasmablastic lymphoma, as we know, it is aggressive type of B-cell lymphoma. However, this has signaling pathway not assessed in this this type of aggressive B-cell lymphoma. Our study is our study is expression of this pattern in a series of plasmablastic lymphoma, ABV positive and negative, compared to its against well-defined activated diffuse large B-cell lymphoma. Next, please. Next. So this is our material, and we 31 plasmablastic lymphoma cases and the 18 diffuse large B-cell lymphoma ABC type were assessed. The RNA from formalin fixed paraffin embedded tissue, diagnostic tissue. So we need the embedded tissue to subject it to expression evaluation of the WNT catenin molecule pathway using what's called N-counting platform using nano-strange technology. The principal component and the clustering hit map were performed and employing a special bioinformatics software called QLookhorse Metabolomics Explorer software. The differential expression of a significance of one gene is defined as having minimum 2.5-fold change with significant p-value. Next, please. So our result is the expression of YMT beta-catenin signaling inhibitor, namely CXXC4, SFRB2, or DKK1, were significantly higher among plasmablastic lymphoma compared to the ABC diffuse large B-cell lymphoma, with a range of a difference range from 9.6 to 3.4. Also, the molecule linked to this pathway activation were elevated in plasmablastic lymphoma as compared with diffuse large B-cell lymphoma. Next, please. This is our results showing the stars, which is the inhibitor for this pathway, shows this is the first one with a significant fold difference between both type of lymphoma. Also, the hash sign, which is this gene and this gene, is also significantly different, which may help in developing a new target therapy. Next, please. Also, we identified a combined simultaneous high expression of the key WNT beta-catenin genes and transforming growth factor beta pathway gene in plasmablastic lymphoma compared to the diffuse large B-cell lymphoma. So this simultaneous high expression, which is called crosstalk between both pathways, identifies the potential for the novel therapeutic strategy targeting this pathway members such as S, MAD, and ID1. Next, please. So if you look to this heat map illustration in diffuse large B-cell lymphoma with the blue color, whereas the plasmablastic lymphoma with purple color. So if you look to this signaling pathway expression in both type of lymphoma, which we start with transforming TGFB signaling pathway, we'll see in the left side, the majority are the expression are low, as it is green type according to this leader. In the right side, there is the majority are red color, which indicate high expression of this gene in the plasmablastic lymphoma. In a similar way, in WNT beta-catenin pathway, a similar pattern of expression. With this crosstalk or simultaneous overexpression may be identified a targeting therapy later on. Okay, next, please. Also, we found transforming growth factor beta pathway gene, namely ID1, SHC1, SMAD4, and ACVR1C, were overexpressed as well in plasmablastic lymphoma compared with diffuse large B-cell lymphoma. Next, please. Again, see this like box plot showing in the blue one is the diffuse large B-cell lymphoma and purple one is the diffuse large B-cell lymphoma. See the significant difference of overexpression of this gene, the 4 genes, this associated transform growth factor beta pathway gene in relation to diffuse large B-cell in relation to the plasmablastic lymphoma. There is a significant overexpression between both type of lymphoma. Next, please. And finally, we also identified a distinct differential expression of messenger RNA related to WNT beta-catenin signaling between both types of lymphoma. Next, please. Again, this is a heat map showing differential expression. If you look to the other hand, again, the blue one is diffuse large B-cell lymphoma, whereas the red one is plasmablastic lymphoma. If you look to this gene related to plasmablastic lymphoma in the bottom one, we will see all these are by red color, which indicate high expression of gene compared to this diffuse large B-cell lymphoma, which appear in the right color in the left side. Next, please. And this is my conclusion. Expression of YNT beta-catenin signaling inhibitor, namely SXC4 and SFRB2 DKK1, were significantly higher among plasmablastic lymphoma compared to ABC type diffuse large B-cell lymphoma. Also, molecular linked with this pathway signaling activation were elevated in plasmablastic lymphoma compared to diffuse large B-cell lymphoma. We reported combined high expression of two pathways, which is WNT beta-catenin and TGF beta pathway molecule in plasmablastic lymphoma to diffuse large B-cell lymphoma compared to diffuse large B-cell lymphoma, which may identify potential therapeutic targeting pathway members such as SMAT4 and the ID1 as being evaluated with effective result in a solid tumor. Oh, and this, thank you, the last slide. Thank you.
Thank you, Dr. Ghalib Al-Yamani. Our next presentation titled Untargeted Metabolomics Identified Key Metabolic Pathway Altered by Thymoquinone in Leukemic Cancer Cells, presented by Dr. Asma Al-Ghamdi. Dr. Asma Al-Ghamdi received her Master of Science from Biochemistry at King Abdulaziz University. She is interested in medical genetics, epigenetics, and hematology as a field to pursue her career. Her research interests lie primarily in the area of is the plant medicine and therapeutic product and developing the drug delivery and cure genetic and epigenetic disease. Dr. Asma Al-Ghamdi can start the presentation. Thank you.
You are welcome. You can hear me?
Yes, you can start, please.
Okay. Assalamu alaikum wa barakatuh, and good evening to everyone. I would like first of all to thank the organizer of this conference for accepting my start. Let me now introduce myself. I am Asma Ahmed Al-Ghamdi. As you can see on the screen, my topic today is untargeted metabolic identify key metabolic pathway altered by thymoquinone in leukemic cancer cells. Next slide, please. Okay, in my presentation, I will focus on 5 main sections: introduction, aim of the study, experimental design, result, conclusion. Next slide, please. Because the failure of the types of treatment used in some cases of leukemia, modern research has tended to treat cancer by use of alternative treatment. One of these alternatives is thymoquinone. Thymoquinone, a naturally occurring anti-cancer compound extracted from Nigella sativa oil. Thymoquinone showed anti-proliferative, pro-apoptotic, and anti-metastatic effects of different cancer cells. Next, please. Metabolomics is the study of cellular metabolism at the global level. Metabolomic study can lead to enhanced understanding of disease mechanism and biomarkers, enhanced understanding of mechanism for drugs, increased ability to predict individual variation in drug response phenotype. Next. The study was aimed to explore the global metabolic impact of thymoquinone on cancer cells, hematological cancer cells, using untargeted metabolomics. Next. In experimental, we used 2 cell lines, JORKIT and HL60 cells, and treated with various doses of thymoquinone. Metabolomics was done by using LC-MS bioinformatic analysis. Next. The metabolome profiling that changed by thymoquinone treatment, measurement by extracted the cell using a combination of acetone methanol solvent. Then injected the sample into LC-MS. The total metabolite identification is 335 feature metabolite in HL60 JORKIT cells. 302 features show p-value less than 0.01. Figure A show the BCA performed on all the samples, which closely cluster to one another. Figure B is heat map indicates thymoquinone have over effect in the metabolic variation on both cell lines. Well, we found a dramatic increase in thiamine glycol, a metabolite recognized to induce DNA damage. Also, we observed a strong decrease in cellular guanine levels, is clearly suggesting alteration in nucleotide metabolism. Next. In cellular pathway, the apoptosis is a major contribution in maintaining tissue homeostasis. Thymoquinone changes the cell metabolic rate and induces apoptosis. In HL60, phenylalanine metabolism show higher impact by thymokinone treatment. It activates OFROC and it induces apoptosis. Also, linoleic acid metabolism change cell proliferation and induce apoptosis. In Jurkat cells, arachidonic acid metabolism, higher variation and changed by thymokinone. Another higher impact by thymokinone treatment is tyrosine metabolism that interlink with other metabolic pathway like glutamine and tyrosine kinase, which is the downstream activation of apoptosis. Next. We identify some pathway and component that affected by thymokinone treatment. One of these pathway is TCA metabolism and amino acid metabolism. Thymokinone change the metabolism compound in TCA cycle. The K metabolite in TCA cycle is glutamine, is converted to alpha ketoglutarate. Glutamine in HL60 cell shows significantly reduced by thymokinone, but in Jurkat significant change not observed. Alpha ketoglutarate is a creation of cell proliferation by thymokinone in both cell line. Diethyl fumarate observed to reduce its circulation by thymokinone in both cell line. Next. In methylation, cysteine and methionine metabolism play a major role in DNA methylation. Thymokinone treatment has high impact on metabolite responsible for DNA methylation and epigenetic modification. Metabolite homocysteine and L-methionine observed reduced accumulation by thymokinone treatment in both cell lines. There was heterogeneity between HL60 and Jurkat cells, but thymokinone interfered epigenetic modification in both cell lines. Next. The conclusion of our study, we first time showed the metabolic landscape of cancer cells during the thymokinone treatment. Thymokinone globally alter metabolome of cancer cells. Thymokinone treatment alter primary nucleotide metabolism and promote metabolites involved in genomic damage and ultimately cell death. Finally, our research is dependent on hadith of Prophet Muhammad, peace be upon him. He said, use the black seed, which is a healing for all disease except Assam, and the Assam is a death. Next. I want to say thank you to all co-authors for all co-author, Dr. Hani Chaudhry, Dr. Muhammad Imran Khan, Dr. Mazen Zamzami, Prof. Muhammad Gari, Prof. Abdurrahman Malki, and Muhammad Rajid. Next. If you have any question you would like to ask, you can send to my email. And for more information about paper, you can check my page in ResearchGate. Next. Thank you for listening to me.
Thank you, Dr. Al-Ghamdi. I want to remind all the attendees that you can submit your question in chat box. Our next presenter, Dr. Majid Al-Ammari. Dr. Majid Al-Ammari is a Saudi board certified in internal medicine. He's currently a second-year adult hematology fellow at King Fahd Medical City, Riyadh. He will present his presentation title is Safety of Ambulatory High-Dose Methotrexate Administration Among Hematological Malignancy Patient in Tertiary Care Center. Dr. Majid, you can start your presentation.
Thanks very much. Assalamu alaikum. First, I would like to thank the organizing and scientific committee for accepting our abstract. I am Dr. Majid Al-Ammari. I am adult hematology fellow at King Fahd Medical City. I am here presenting our abstract on behalf of Dr. Ibrahim Mu'tabi and the rest of the team. Our abstract is about the safety of ambulatory high-dose methotrexate administration among hematological malignancies patients in a tertiary care center. Next, please. So methotrexate is an anti-metabolite that merely acts through the inhibition of the enzyme dihydrofolate reductase and the subsequent depletion of the intracellular folate stores. High-dose methotrexate is defined by the dose of more than 1 gram per meter square. The utilization of high-dose intake most commonly in solid malignancies such as osteosarcoma and hematological malignancies such as acute lymphoblastic leukemia and non-Hodgkin lymphoma. Next, please. So urine alkalinization by using IV sodium bicarb and calcium liquefolic acid is used to facilitate clearance of MTX. Both of these are two important steps in the MTX clearance to avoid and minimize the side effects such as nephrotoxicity and hepatotoxicity. So most of the institutions are requiring patients to be admitted with a minimum of length of stay of around 72 hours until MTX clearance, which is achieved when it reaches the level of MTX less than 0.1. So next. Next, please. Okay. In our study, we are assessing the safety of ambulatory high dose intakes among patients treated in a tertiary care center. We used regular laboratory monitoring, adequate oral hydration, and oral medications were utilized to enhance the methotrexate clearance without the necessity to use devices at home for infusion or the need for admit the patient to the hospital. So next, please. So this trial is open-label, single-arm study. It aims to evaluate the safety of high-dose methotrexate administration in an outpatient setting among adult patients with hematological malignancies in a tertiary care center. This study aims to cover a cohort of patients with hematological malignancies from 14 to 60 years of age, year-old, treated at King Fahd Medical City, who was scheduled to receive high-dose intakes from February 2020 to February 2021. So I will start here with the treatment protocol is shown in figure 1. Next, please. In figure 1 here, we see the high-dose MTX. On the day of this protocol we used for the ambulatory high-dose MTX, you can see here that we started on the day before high-dose methotrexate infusion by administering to the patient acetazolamide tablet and sodium bicarb tablet, and encouraging the patient to use oral fluid intake at least 3 liters per day. After on the day of methotrexate infusion, if the urine pH level is 7 or less than 7, we give the patient IV sodium bicarb to maintain a good level of urine pH more than 7. And after that, we are following the patient daily with MTX level and routine labs, and we are adjusting the calcium leucovorin based on the MTX level every day. Next, please. Here you can see the ambulatory high-dose MTX workflow that when the patient is determined to receive the high-dose MTX based on the physician discretion, then the patient will be assessed for the eligibility of the study, and the patient will be educated about the study and his caregiver, and when adequate that the patient is compliant and he can be enrolled in the study, then we take a written consent from the patient. Then the patient will be, through a hematology coordinator, will be scheduled to labs before 24 hours from the high-dose MTX administration, and a day for high-dose MTX administration will be scheduled in the oncology therapy unit, and after that the patient will be scheduled to receive daily labs including MTX, and the patient will be followed daily. Next, please. So in total, until now we have 15 patients. We have 27 cycles we recorded until now. Around 70.37% of the patients were diagnosed with diffuse large B-cell lymphoma. Out from the 27 cycles, 14 were for males and 13 were for females. Next, please. So in terms of comorbidities, most of the patients, they didn't have comorbidities. Around 6 cycles were for patients with hypothyroidism, and 1 for HIV, and 3 cycles were for sickle cell trait and common variable immunodeficiency. Next, please. So here in this figure, we can see the baseline urine pH. We can see that around from 27 cycles, 20 cycles, the patient didn't even need for IV sodium bicarb before the high-dose MTX administration. With that give us an idea that the oral acetazolamide and oral sodium bicarb was enough to maintain a good level of urine pH more than 7. Next, please. So 48.1% of the patients achieved MTX level less than 0.1 by 48 hours, and 88.8% achieved the same level by 72 hours. Only 3 patients didn't clear their MTX level. By the end of the 72 hours, 1 patient was admitted due to acute kidney injury. The second was managed as outpatient at his elevation of sodium bicarb. His elevation of MTX was amid the mid of COVID-19 bed crisis. And the third one refused admission as his MTX was borderline 0.12, and he preferred to follow up at his hospital at his hometown. The last 2 cases, they cleared their MTX level without complications. Next, please. By 72 hours, around 29.63% had reversible asymptomatic elevation of creatinine. All of them were grade 1. And by 72 hours, 44.44% had grade 1 reversible hepatotoxicity. Around among the 27 cycles, only one patient was complicated by acute kidney injury that necessitated admission for supportive care, which is totally reversible. As the patient wasn't compliant to the treatment protocol, he was excluded for the subsequent cycles. Here, I can show you in the next figure a cost saving figure in the next slide. Next, please. So one of the benefits of our study is to compare the cost, the approximate cost of the inpatient high dose MTX versus the outpatient high dose MTX. If we compare the inpatient high dose MTX cycle, it approximately costs around 22,000 riyals. In compared to the outpatient high dose MTX cycle, it will compare only around 1,200 riyals. Next, please. So in terms of patient satisfaction, we can see most of the patients were satisfied with the ambulatory high dose MTX. Around 87% of the patients were satisfied with it. So next one. So in conclusion, our preliminary results suggest that the ambulatory high dose MTX is safe, it's cost effective, and it's more comfortable for the patient. So this result is encouraging for use of this approach more frequently, as it decreases the hospitalization, and thus it will reduce the cost, it will increase the patient satisfaction, and it will help to solve the issues of bed crisis. So at the end of my presentation, I would like to thank the patient. I would like to thank our colleagues who shared their patient experience with us, and I would like to thank the whole department for their unlimited support. Thank you.
Thank you, Dr. Amari. Our next presentation, titled Premature Cellular Cessation Appear Visible Without Clot Pulse Post Non-Myeloablative Transplantation in Adult Patient with Severe Sickle Cell Disease. Dr. Musab Damlet is working as a consultant at adult hematology and transplant and assistant professor at Saud bin Abdulaziz, King Abdulaziz Medical City of National Guard, Al Qatar, Riyadh. Dr. Musab Damlet, the floor is yours.
Thank you, Dr. Muhannad, and I would like to thank the organizing committee for choosing this abstract for oral presentation, which essentially looked at the feasibility of stopping sirolimus early in the setting of allogeneic transplant in adults with sickle cell disease. Next slide, please. So can you please put all of the bullet points in this slide? So as you know, allogeneic transplant for adult patients with sickle cell disease is a curative treatment, but the main limitation is that it's associated with morbidity and mortality, especially if conventional conditioning protocols are used. That being said, over the last few years, the non-myeloablative protocols have been developed, and this permitted the use of allogeneic transplant in adult patients with sickle cell disease. In such platform, sirolimus is commonly used for graft versus host disease prophylaxis, and it frequently results in a state of mixed chimerism where you have donor and recipient cells post-transplant. Next slide, please. Now, this is our experience with transplant in adult patients with sickle cell disease. Those were a total of 110 patients that were transplanted over a period of 5 years. And as you can see, the event-free survival is estimated to be around 87% and an overall survival of 97%. Predominantly, all of the events that were observed, whether it's event-free survival or overall survival, were due to graft failure. And some of the patients that developed graft failure had succumbed with infections and bleeding, and this has been the only cause of transplant failure. But as you can see, the results are overall quite excellent in adult patients with severe sickle cell disease. Next slide, please. This is also a shared experience from our center and 2 other centers in the US, where included patients that were followed for a relatively long period of time, because the main concern that we have with the use of a non-myeloablative regimen is graft rejection. So as you can see here, it's a cohort of 122 patients with the same protocol. The median follow-up was 4 years. We observed no cases of graft versus host disease of the chronic variant. And as you can see on the right-hand side, the myeloid chimerism hovers around 80 to 90%, whereas the lymphoid chimerism stays around 50 to 60%, and in fact stays stable after stopping sirolimus. And the median time on sirolimus was somewhere around 1.5 years, or 489 days. Next slide, please. So the objectives of this study was to really examine whether sirolimus can be stopped early. And early means when the lymphoid chimerism is less than 50%. And the reason for that is prolonged sirolimus exposure is associated with some untoward toxicities. And in addition to it being preventative for conception, and some patients, of course, do not like that. Specifically, we were looking at kinetics of lymphoid chimerism after sirolimus is stopped. We were also looking at hemoglobin and hemoglobin S parameters, and of course, the incidence of graft loss, which is the main objective of this analysis after stopping sirolimus. Next slide, please. So this was an IRB-approved study. We looked at adult patients that received allogeneic transplant for severe sickle cell disease over a 5-year span of time. 12 months of follow-up was required because this is the period of time where we would start tapering sirolimus. The conditioning protocol consisted essentially of alemtuzumab of a total of 1 milligram per kilo given over 5 days and escalating doses, as well as TBI in 1 session of 300 centigrades. Followed by peripheral blood stem cell infusion with a target dose of more than 10 million if possible. Sirolimus generally is given for about a year and most of the time longer than that. And we measured post-transplant chimerism at regular intervals, so at day 100, 180, and then annually. Next slide, please. So a total of 110 patients over this time span underwent transplant. At the time of data cutoff, 62 patients had discontinued sirolimus. 10 of them, in fact, had graft failure prior to stopping sirolimus. So while they were actively on GVHD prophylaxis, they unfortunately suffered graft loss and they were excluded from further analysis. The median time to graft loss in those patients was around 130 days with the range that you see. The remaining 52 patients we looked at more carefully and dissecting their CD3 chimerism at the time of sirolimus taper. So some patients had more than 50% chimerism and they were deemed adequate, and this is the ideal setting. But we had 2 other groups of patients, one with less than 50% chimerism, but their chimerism was in fact stable and the patient had suffered some side effects from sirolimus. So the decision was to start tapering. And then a third group where we, in fact, did not know or had unknown lymphoid chimerism, but we only had whole chimerism, which was again stable at 50% or more, and the patient had suffered side effects. But in fact, this group had 3 patients that decided to stop sirolimus on their own without physician approval. Next slide, please. So these are the overall results. So we stratified these groups into the 3 cohorts, as you can see, and we looked at their baseline characteristics in terms of their age, gender, pre-transplant characteristics, donor, ABO matching, etc. And generally, they were the same. Where we found the difference essentially was with the median CD34 dose that was infused. So patients that had adequate lymphoid chimerism had a median of 12 million CD34 dose cells, whereas it was around 10 million for the other 2 groups. The CD3 or lymphoid dose was essentially the same across the 3 groups. Next slide, please. Looking further into their characteristics, prior to taper, you see that the median hemoglobin S, or the median hemoglobin was rather similar. Hemoglobin S was higher in the adequate lymphoid chimerism group, and the reason for that is because of the higher proportion of sickle cell trait in this group. Otherwise, hemoglobin post-taper, whether it's hemoglobin, total hemoglobin or hemoglobin S, was in fact similar. Next slide, please. This is looking at the hemoglobin trend post-transplant across the 3 groups. And what is interesting, as you recall, I told you before that the pre-transplant hemoglobin, the median was around 9.5.
And what you're seeing here, essentially post-transplant, the hemoglobin rises into the normal range and it stays at this range post-transplant, and it was essentially similar across the three groups. Next slide, please. We look at the chimerism. So you look at the lymphoid chimerism, significantly higher in the adequate group as expected. The time what's interesting though is post-stopping sirolimus, the lymphoid chimerism and the myeloid chimerism essentially is the same, as you can see in the middle, hovering around mid to high 60%, which was in fact quite surprising. But that being said, the time on sirolimus therapy was significantly lower in the low and unknown lymphoid chimerism groups. But most importantly, after stopping sirolimus, we did not notice any cases of engraftment failure, and we did not have any cases of mortality, which essentially is the main finding of the study. Next slide, please. So the chimerism post-transplant, in orange is the lymphoid and in blue is the myeloid, and you see we get results that are very similar to what we would have expected otherwise. Next slide, please. Looking specifically at the groups that had adequate versus low lymphoid chimerism, you see that their progress essentially is overlapping. And what is nice, in fact, is that after stopping the sirolimus in the low lymphoid chimerism group, the chimerism continues to increase, and then it finally tends to plateau off after a reasonable follow-up time. Next slide, please. So in conclusion, it looked like early stopping of sirolimus in patients that had low but stable lymphoid chimerism appeared feasible, and without having any cases of declining chimerism or graft loss, which in fact was quite interesting to see. Next point, please. So further evaluation, of course, is important because of the side effects that we see with sirolimus treatment. And we think we are, in fact, in the phases of planning this prospectively, particularly in patients that are more prone for sirolimus toxicity, such as metabolic syndrome, etc. Next point. And of course, we are interested in general for more long follow-up of this cohort in total to see how stable is the graft function over time, regardless of the lymphoid chimerism. Next slide. So finally, I would like to acknowledge all of our members from the multidisciplinary team, which have taken, of course, an important role in making this a success. And importantly, our patients and their caregivers for whom all of this essentially cannot happen. Thank you very much for your attention.
Thank you, Dr. Musab. Our next speaker will be Dr. Ragad Al-Aql, is a senior medical student at King Saud bin Abdulaziz University for Health Science in Riyadh. She will be graduating soon, and she is interested in both ophthalmology and pediatric field, more specifically pediatric hematology. Her presentation titled The Impact of Total Parenteral Nutrition Survival Rate and Complication in Pediatric Stem Cell Transplantation. Please, Dr. Ragad, you can start your presentation.
Okay, Assalamu alaikum. So my name is Ragad Al-Aql. I'm a senior medical student at King Saud bin Abdulaziz University for Health Sciences in Riyadh. So this is our topic. It is about the impact of total parenteral nutrition on the survival rate and complications in pediatric stem cell transplantation. Next, please. Okay, for the background first, hematopoietic stem cell transplantation is considered as a curative treatment for both malignant and non-malignant disorders, but patients might present with some complications such as mucositis, vomiting, and diarrhea, and these complications are very common. And so the nutritional support with total parenteral nutrition is usually used. But there are some complications which we fear, and these complications are related to the central venous catheter, such as infections, metabolic disturbances, including abnormal liver function. So the aim of our research was to identify the complications of TPN and to estimate its impact on the survival rate. Also, this study compared between the rate of complications between TPN and non-TPN patients. Next, please. For the methods, this was a cohort retrospective study in which electronic charts of pediatric patients who fit our inclusion criteria were reviewed. And our inclusion criteria was all pediatric patients, both gender, who underwent stem cell transplantation between 2015 until 2018 in King Abdullah Specialist Children's Hospital in Riyadh. And the number of pediatric patients we got was 162. Next, please. For the data collection, patient chart on best care system were reviewed, and we collected data about the clinical characteristics like the age, gender, primary diagnosis, diagnosis date, type of transplant, and the nutritional profile. And I will show you later on a chart about that. Also, for the conditioning and treatment modalities, data were collected including the type of conditioning, if it is chemotherapy or radiotherapy, the regimen intensity, and the duration. And lastly, we looked for complications including mucositis, graft versus host disease, hepatic veno-occlusive disease, bacteremia, and finally the patient's outcome. Next, please. For the result, a total of 162 hematopoietic stem cell transplants were identified during the period I mentioned before, and patients' characteristics are shown in this table. 124 of them were allogenic, and 38 were autologous. And for their age, 30 of them were less than 2 years old, and about 2 to 5 years old. 38 of them were about 2 to 5 years old, and 63 of them were from 5 to 10 years, and 31 of them were greater than 10 years old. And for their gender, 79 of them were males, and 83 were females. For the source of stem cell, 135 were bone marrow, and 27 were peripheral blood stem cells. For the type of conditioning intensity, 41 were reduced, and 118 were myeloablative. For the type of nutrition, 96 were in TPN, and 8 were on the nasogastric tube, and 58 tolerated the oral intake. For the outcome, 16 were dead, and 146 were alive. And for the diagnosis, 31 were presented with hemoglobinuropathies like sickle cell anemia or thalassemia, and 21% were having a brain tumor, and 13% were for acute lymphoblastic leukemia, and 35 presented with other diagnoses like MHC2 deficiency and so on. And here in the allogenic group, the indication of allogenic transplant included hemoglobinopathies in 50 patients, or 31%, and brain tumor in 34 patients, or 21%. Next, please. Out of 96 patients who were dependent on the TPN, 64 patients, or 66.7%, had severe mucositis, in comparison to 17 patients, or 25.8%, who were either on the nasogastric tube or tolerated the oral intake, and the p-value was 0.00. And also here in the hepatic veno-occlusive disease, it was seen in 14 patients, or 14.6%, who were receiving the TPN, compared to none in the non-TPN patients, and the p-value was 0.001. However, there were no statistically significant differences in graft versus host disease, both the acute and chronic, and bacteremia and patient outcome between both groups, TPN and non-TPN patients. Next, please. So in conclusion, the nutritional support using TPN is used in the majority of patients, especially post-myeloablative conditioning associated with severe mucositis, and TPN was associated with veno-occlusive disease, especially in hemoglobinopathy patients who received the myeloablative therapy. And this may emphasize on the use of preventative measures such as fluid restrictions, use of diuretics or defibrotide in high-risk patients. And a larger study is needed to confirm our results and to control confounders at a larger scale. And that's it. Thank you so much.
Thank you, Dr. Ragad. Our last poster presentation for today will be presented by Dr. Hind Salama. Dr. Hind Salama is working as one of the consultants at King Abdulaziz Medical City in Riyadh with a special interest in acute lymphoblastic leukemia and histiocytic disease. She has 3 published papers as the first author in histiocytic disease and has been a presenter in many local meetings. She did an oral presentation in ASH 2020, virtual meeting, and poster presentation in ASCO Quality 2020. The presentation title, Reduced Futile Acute Care Service for Terminally Ill Cancer Patients, the Dignity Project. Dr. Hind, the floor is yours.
Thank you, Muhammad. Thank you. I would like to thank the Saudi Hematology Society for accepting my abstract. We will move in my abstract from pure hematology to quality. Next, please. Any problem with the slide? Do you want me to share my slide or? Okay. Next, please. You can hear me, Muhammad?
Yes, I can hear you.
Is there any technical problem or?
Yeah, I cannot see your presentation.
Because they should share it. If they don't want it, they can share it. Yeah. Muhammad, do you want me to share it from my side?
Yes, if you can, maybe.
I will try. Just allow me. Yeah, I can. Can you see it now? Is it clear now? Should I start?
I cannot see any. Yeah, now I can see. Yes, please
Okay.
start.
I will continue. Okay, it's mainly a quality project. It's about reducing futile acute care service for terminally ill cancer patients. So we noticed at King Abdulaziz Medical City, Riyadh Oncology Department, that some of our patients with palliative intent, they underwent acute care service, including ICU admission, intubation. So we conducted a quality improvement project with an aim to reduce the utilization of such futile service for cancer patients with an aim to treat as palliative, not curative. So we noticed the main reason for this intervention is lack of documentation of goal of care at the time of patient deterioration. So, so we did a fishbone analysis to know why there is delayed documentation of goal of care in the. So we noticed that there are 4 factors related to process, where there is no standard process to decide goal of care, lack of goal of care policy, no clear point when should the physician reassess the goal of care, factors related to physician, where most of the time there is no enough time for documentation and discussion with family, increased workload and lack of staff, and also one of the reasons why some physicians feel insecure and uncomfortable to discuss goal of care with patients and family, especially difficult families. Also, there was factors related to materials, lack of educational materials for the family about the role of palliative care, and patient and family. Most of the time, especially in our culture, the patient or family refuse the concept of no acute care service, refuse the concept of palliation and change of goal of care. So then we went and we did our project in 3 phases. The pre-intervention phase, where we analyzed 135 patients who died as inpatient from November 2017 to May 2018, including solid malignancy and hematological malignancy. All of them were adults above 14 years with advanced cancer who were assigned for palliative intent approach, and they died as inpatient. So the variable that we look at was the timely documentation of goal of care, which we define it as the availability of electronic documentation of goal of care or no code status before the need for acute care service intervention. And also we monitor the acute care service intervention, including the critical care response team activation, the cardiopulmonary resuscitation, and the intensive care unit admission. We monitor also referral to palliative care, and we also calculated the cost of intensive care unit bed. We did not calculate the mechanical ventilation, only the bed per day. So then we went and we did our intervention phase after we had our baseline data. And in our intervention phase, we introduced 6 steps for improvement. We name our intervention Medrem model, where each letter referred to certain intervention. And this period lasted for 6 months. And then after that, we did the post-intervention analysis, where we look also at 174 patients with the same eligibility criteria, who died also between December 2019 to June 2020, which is also 7 months. And we compare the two, we look at the same variable and we compare the 2 phases together. Before I move to the result, I will just introduce you through some steps that we did to improve the practice. So this is our goal of care. This is our process map, which is already there before, where we discuss each new cancer patient in a multidisciplinary tumor board, and then we decide the aim of treatment, curative or palliative. But what we add after our project that we included here, this part, if the patient is decided for palliative care, then the consultant has to discuss the next day with the family or patient the goal of care, and if they accept it, he should have the flag in the electronic system signed by 3 consultants, the flag of no code. If they did not accept, he will arrange for a multidisciplinary meeting, including the social workers, the religious affair, and discuss the issue with the family again after giving them some time to think of the concept. And then if they agreed, fine. If they did not agree, another multidisciplinary meeting. And then finally, either he will respond to the family or patient wish, or he will refer the case to the ethical committee. The aim of this early discussion after diagnosis or after discussion in tumor board is to allow them some time to absorb and understand the information, rather than our normal practice that we just discuss the goal of care when the patient really need intervention like ICU admission. Also, one of the steps that we did, that we added the goal of care icons as mandatory icons in our tumor board. So the tumor board moderator has to choose either support or comfort, which means palliative or full code, before he signed the notes. Otherwise, he cannot sign. Also, we added the same icon in the outpatient progress note, so we will not miss the one at outpatient. Also, one of the nice steps done in collaboration with our palliative section, that the creation of the palliative care educational booklet in Arabic, which explain the concept of support care, comfort care, the palliation, and what are the service that is going to be given to the patient if he is for palliative. So once we decided in the tumor board that this patient is for palliative intent, the booklet should be distributed to the family, or the family most of the time here. So now we move to the result. The general characteristic of the patient in the pre and post intervention was almost the same. The demographic, there is no statistical difference. When it comes to the result, if we look at the acute care service in the pre and post, there is less utilization of critical care response team activation, 14% versus 25% in the pre-intervention. Less intensive care unit admission, 12% versus 26% in the pre-intervention. Also, less total ICU days admission, 415 versus 582. So we saved 167 days of ICU admission. And also less CPR. And the most significant difference was improved documentation of goal of care. So the timely documentation of goal of care before the need for acute care service improved to 83% versus 59% in the pre-intervention, with a very significant p-value of less than 0.001. However, The referral to palliative care remained the same, the rate of referral in the pre-intervention and post-intervention. As well, more patients died less than 30 days of referral to palliative care. That is in the pre-intervention as well as in the post-intervention. So this reflects delayed referral to palliative care, and this is an area that needs improvement in the future. The bar graph here reflects the same improvement in the timely documentation of goal of care in the post-intervention as compared to pre-intervention, less usage of acute care service for palliative patients in the post as compared to pre, and less patients died in ICU in the post-intervention. When it comes to cost saving, as I mentioned, we saved 167 days ICU admission. So we calculated the cost because we have the cost of ICU day without mentioning the mechanical ventilation is 7,875 riyals per day. So we saved during the project period 1,315 and 125 riyals in 7 months, equivalent to 2,254.5 riyal annually. So there are also other cost saving attained from less utilization of critical care response team, cardiopulmonary resuscitation, mechanical ventilation, less utilization of images, laboratory, and other futile procedure. So these costs we did not measure. Maybe in the coming future we will do. So the actual cost saving is way higher than the calculated cost saving. For us, the most important benefit was reducing patient suffering and inconvenience and maintaining their dignity during their care with terminal illness. Our future direction will focus on sustaining the success by incorporating the interventions that we did in the care process and electronic medical record. We are planning to improve different components of the process. We are planning also to assess patient and caregiver satisfaction. To conclude, early determination and documentation of goal of care for patients with terminal cancer resulted in reduction in utilization of acute care service resources, including admission to intensive care unit with an overall reduction in cost, and more importantly, preserving patients' dignity. Last, I would like to acknowledge the Dignity Project team, whoever share in bringing this project to this step from each section, from hematology, oncology, palliative, gynae oncology, biostatistician, and our patient educator. And thank you so much.
Thank you, Dr. Hind Salama. I would like to thank all the speaker and all attendees again. Now we will take a break for 15 minutes. While waiting, you can enjoy the poster display session, and we'll be back at 9:30 for award ceremony and e-recognition for us and e-recognition. Thank you.
بسم الله. السلام عليكم. Once again, we'll start awarding ceremony for the abstract winners, followed by sponsors recognition. I appreciate and I'm very thankful for those who submitted their abstracts. Hopefully, we'll get more submission next year, inshallah. We have this year six winners, and as usual, 3 juniors and 3 seniors. We'll start from the junior, and the third runner-up from junior abstract winners is Faisal Al-Jaber for splenectomy perspective for hematological disorders. Can we get the slide? Yes, this is the Faisal Al-Jaber. Thank you. Congratulations. Then the second junior runner-up is Hadil Al-Haddad for transfusion-dependent anemia and cytopenia secondary to parvovirus. Congratulations, Hadil. The third junior, or the first actually, runner-up was Majid Al-Ammari for safety of ambulatory high-dose methotrexate. Congratulations, Majid. And hopefully for the 3 and others, see you next year, inshallah. For the senior winners, we have again 3. I will start from the third runner-up as Dr. Hind Salama for reducing futile acute care services for terminally ill cancer. Congratulations, Hind. The second runner-up is Mus'ab, Dr. Mus'ab Damlaj, for premature serous cessation appears feasible without graft loss. Okay, congratulations, Mus'ab. Inshallah. Now we'll go to the last and the first runner-up is Dr. Riyad Al-Faqih for clinical course and outcome of COVID-19 in hematopoietic stem cell transplantation. Congratulations, Riyadh, and I hope I don't see such abstracts regarding COVID or similar next year, inshallah. Thanks. Maybe now Firas will do the recognition for sponsors now. Thanks.
Thank you, Dr. Muharib. Congratulations to the winners and congratulations to everyone who has been working on research in the hematology field. So I'll ask the technical to share the screen kindly. Ayman, let's share this the other screen or presentation. Okay, so I mean without the support from several pharmaceutical companies, we would not have been possible. It would not have been possible to organize such an event, and with very huge audience. We had more than 25,000 registrants and more than 7,000 attendees on the platform today, plus the YouTube. So I will start in order by recognizing the leading company in supporting this event, which is the platinum sponsor Janssen. So special thank you for the team as well as for the company. Moving to the next. The gold sponsor is we have AbbVie. A special thank to the AbbVie, and next, please. Also to Amgen. Next. Astellas. Next. AstraZeneca. PMS. Gilead, Novartis, Sanofi, Takeda, and now next to the silver sponsors, Biologics, Biomarine, Biocrine, Pfizer, Roche, and Roche Diagnostic. So by and also survey, Sudair, and by this we reached to the end of the recognition of the sponsors. We have 18 sponsors, so special thanks to all of them. And I have to say, although the COVID pandemic has been disastrous from several ways in the humanity, however, it did help accelerating the digital education, including the scientific one, like this event today. By far, I mean, the attendees of this event is much higher than last year, and we hope that probably we will continue in the virtual events. Hopefully, however, we will have also face-to-face, so we will be moving, inshallah, toward a hybrid format of future events. So by this, we reached to the conclusion of the sixth Saudi Hematology Day. I would like to remind you that at 9:50, 13 minutes from now, we will have the first satellite talk. It will be about advances in relapse refractory CLL management. It will be given by Dr. John Gribben, who is a very renowned international speaker. He's also the EHA president. I highly recommend your attendance to the activity, and it is also included as part of the program. Thank you all, and see you in almost 10 minutes.
Gracias.
Dr. Gribben, do you hear me? Dr. Gribben?
Yeah, hi.
Hi. Thank you for joining us today.
Yeah, thank you.
My name is Firas. I'm the president of Saudi Society.
Oh, well, thank you so much for welcoming me personally. Very kind of you.
No, actually, it is our honor to have you today. We are supposed to start in 3 minutes. I was wondering if you would like to share your presentation and share your screen.
That's what I'm trying to do. I've been trying to reach the technical people to give me some help, so I'm trying to do exactly that right now. I also wasn't sure because I did send in the slides whether they were already there. So the
I see it's loading. Yeah, so I think it's coming now.
Ah, okay. It just took such a long time to come, so it's now there. Okay.
Yeah, the loading time is a little bit longer.
Now, how do I get this to? They spent ages showing me all of this the other day, but now, of course, I've forgotten everything. It's a case of how do I get the slides to actually show?
Let me see if I can get someone to help you. So I do see your screen now, or the presentation.
I just can't get the slides to move. That's all.
Okay. Yeah, let's. Okay, okay, Prof. Gribben, I figured out why you are unable to. So actually, I mean, the technical team are the one who's sharing the screen.
Yeah.
Yeah. So, so you can just say next whenever it's time.
So what I'm showing, what is right here is the slides that they're. Okay, perfect. Okay, so I just tell them. Okay, okay, perfect. In that case, I'm ready to go whenever the talk is supposed to start.
Okay, so we are good to start now. So it's my great pleasure to introduce Professor John Gribben. Professor John Gribben is a professor and consultant medical oncologist at Barts and the London NHS Trust. He's also the president of European Hematology Association, as well as he has been taking the lead in with several investigations with a primary focus in CLL. He will be talking today in deep dive CLL today for relapse refractory disease as part of AbbVie Satellite Symposium. I would like to remind the audience, and we have a huge audience, more than 6,000 now with us. I would like to remind them to kindly write the question in the question tab, and then we'll address them at the end. Dr. Gribbin, the floor is yours.
Thank you very much for this very kind invitation. Good evening to all of you there, and thank you for taking the time to listen to what I have to say today. And I'm going to be talking about CLL, and we're going to be talking and looking in more detail at the treatment of relapsed and refractory CLL. Can I have the next slide? So just a disclaimer, this meeting, obviously this is a satellite symposium, was organized by AbbVie. The views and opinions are my own and don't necessarily reflect those of AbbVie. And AbbVie does not endorse the use of unregistered products or products outside of their registered indication, which is not a component of my talk today, but of course I'm very happy to talk about off-label use in terms of many of the very interesting clinical studies of venetoclax combinations that people are looking at in the treatment of CLL. Next slide. And here are my disclosures, which I'll leave up for just a moment as requested by the organizers. Clearly, I work with many companies, including, of course, AbbVie, to look to improve the outcome for our patients. Next slide. So there's been a real evolution in the treatment of CLL, and going back not so very far away, we were looking to really alleviate patient symptoms. Next slide. Then with the advent of chemoimmunotherapy combinations, we're looking to increase the response rates and the quality of responses. Next slide. And then in the last decade, we've seen an absolute explosion in the number of agents available to us to be able to treat CLL, all associated with improving the long-term outcomes in terms of progression-free survival. And then next slide again. And we're now entering an era where we have all of these agents. We're looking to improve the outcome for more and more of our patients, and looking, of course, to improve the overall survival, aiming towards that elusive cure in CLL. Next slide. Now, in terms of relapsed patients, here are the guidelines from NCCN looking at the treatment of patients, and this is those without 17p deletions. And if you look here, what you will see is that in terms of the preferred regimens, and particularly those in category 1, we are talking exclusively now about the novel agents. Acalabrutinib, ibrutinib, venetoclax plus rituximab are the only agents now being recommended in the setting of relapsed and refractory CLL. And you'll see that chemotherapy options have completely disappeared off the frontline recommendations for these relapsed patients. Next slide. And the situation is even more clear in the setting of patients who have relapsed and refractory with deletion 17p or TP53 mutation. Now, a little reminder, of course, that the frequency of deletion 17p's and TP53 mutation increases with each subsequent line of therapy, and it's vital that we recheck patients by FISH and by TP53 mutation analysis each time they progress to a need of treatment. But again, you'll see that the category 1 treatments as recommended by the NCCN do not include any chemotherapy whatsoever. And even, of course, the other recommended regimens, not category 1, also you'll see again, no chemotherapy. Next slide. The same is true for the for the ESMO guidance, which has just been published in January of this year. Barbara Eichhorst is the first author here. You'll see that here we are looking to see how long the previous remission has been, but you'll see again for those patients with TP53 mutations, 17p deletions, no mention of chemotherapy. For patients who have short durations of therapy, no mention of chemotherapy. And you'll see that even in those with long remissions, as I'll show you in a moment from the results of the clinical trials that we're seeing, less and less of a role for chemoimmunotherapy. And only for those patients would you consider chemoimmunotherapy who have a very, very long first remission. But I have to say, as I'll take you through the data in a moment, looking at venetoclax plus rituximab, That would not be my preferred treatment, and I would really look to avoid chemotherapy here. Next slide. So here is the sorts of data that led to the approvals of the agents and why these guidelines demonstrate that we should use novel agents over chemoimmunotherapy. The trial that led to the approval for ibrutinib first was the RESONATE trial, which randomized relapsed and refractory CLL patients to receive ibrutinib or ofatumumab. Not a therapy one would consider nowadays, but the only therapy that was approved for late-line patients earlier on. Now, this median progression-free survival of 44 months in this setting, it may not be what we might expect to see today, because, of course, when this study opened, many of these patients had received 6 and 7 lines of previous therapy and were very heavily pre-treated. But one of the features that became very apparent early on was the finding that those patients with 17p deletions could do very well with novel agents, and certainly much better than we'd seen with previous chemoimmunotherapy. Next slide. This is associated with a side effect profile, but an acceptable side effect profile. But what we should remember is that ibrutinib monotherapy requires continuous therapy, which means that we are potentially exposing our patients to side effect profiles over a long period of time. Now, what this slide also shows you, of course, is that the majority of the side effects decrease over time, but there are side effects like hypertension that decrease over time, and you'll see also things like infection and neutropenia are issues that can consider, and something we have to consider when we're talking about continuous therapy for our patients. Next slide. Now, there are other BTK inhibitors out there now, and of course, acalabrutinib is also licensed and available for this setting. And again, here we have data. This is from the ASCEND trial. This was a trial which randomized patients with relapsed and refractory CLL to either receive acalabrutinib or to receive investigator's choice, which could be bendamustine rituximab, or in this case, could be idelalisib rituximab. And what you'll see again in this setting is that the novel BTK inhibitor acalabrutinib outperformed both the chemotherapy arm with BR as well as idelalisib rituximab. This is one of the first studies that has looked at a novel combination in terms of comparing here idelalisib with acalabrutinib. And largely what drives that poorer outcome with idelalisib is the side effect profile associated with this agent, meaning that we often have to stop the drug earlier. But what you'll see is that the acalabrutinib outperformed the other arms in all subsets of patients examined. Next slide. Again, there's a side effect profile associated with this, but what you also now see is that the side effect profile looks very good compared to what we would see in the setting of chemotherapy, and certainly less than we see with idelalisib rituximab. There are some issues here, and of course, in terms of the grade 3 adverse events of interest, atrial fibrillation did occur, but appears to occur at a lower frequency with acalabrutinib than we see with ibrutinib. There is this mild bruising that occurs with all members of the BTK inhibitors, but major hemorrhage you'll see occurred at the same frequency with acalabrutinib as it did with idelalisib rituximab. Next slide. So what I want to focus a little bit more on today is the fixed duration therapy approach that we use with venetoclax in combination with rituximab. And the approval of this agent was based upon the Murano clinical trial, and design is shown here in this slide for you. 389 patients with relapsed refractory CLL randomized to receive what was considered then the standard of care with bendamustine rituximab for 6 cycles. Venetoclax was combined with rituximab on the basis of phase 1 and phase 2 data, suggesting a synergistic activity of venetoclax with anti-CD20 monoclonal antibodies. The approach here was to do the 5-week ramp up that we do with venetoclax, starting at the 20 milligram dose, 50, 100, 200, to achieve the 400 milligram dose, Then the rituximab is added for 6 cycles. Venetoclax is continued for up to 2 years. And then there's a fixed duration stop point. So unlike BTK inhibitors, when we're using BCL2 inhibitors, we're looking at fixed duration of therapy. There was a subsequent protocol amendment that allowed for patients who progressed to be retreated and crossed over to receive, again, venetoclax rituximab. The primary endpoint of the study was the investigator-assessed progression-free survival, and key secondary endpoints as shown here. The key inclusion criteria were that these patients had to have been previously treated, including a line of previous chemotherapy-containing regimen. They could have prior bendamustine only if the duration of response was greater than 2 years. That is, they were not considered refractory, since those patients may again be randomized to bendamustine rituximab, and they had to have good performance status. Next slide. So what is the typical Marano patient then? Well, 70% of the patients more were male. The median was 65 years of age. They, as you might expect, were ambulatory. 53% of these patients had at least a medium risk for tumor lysis syndrome. Approximately 27% had a deletion 17p. The median prior regimens was 1, and chemotherapy with or without anti-CD20 was, as one would expect, the most common prior therapy that was seen. Now, there were relatively few patients at the time that Marano trial that took place that had received prior BTK inhibitors, but of course we have a great deal more data looking at sequencing of venetoclax and ibrutinib or acalabrutinib that we can perhaps talk about when we come to questions. Next slide. So what we saw was that the study met its primary endpoint, and we saw, when the data was first presented, a very marked improvement in the progression-free survival at that 2-year end of treatment time point, to a hazard ratio of 0.17. Now, the interesting thing, of course, about the study was that at that point, the patients stopped venetoclax, and there's been a great deal of interest, of course, as to what was going to happen to those patients off venetoclax. Now, also on this slide is something interesting, which is, remember I did say that it's my view that chemotherapy should not be offered to patients who have relapsed disease. And it's on the basis of this study here, where we are seeing marked superiority in terms of outcome with venetoclax rituximab compared to chemotherapy, with what many would consider to be our best salvage regimen, that is with BR. Now, if that's the case, why should we offer chemotherapy to any patients when we can clearly see much better outcome with venetoclax rituximab? Next slide. Now, over the next few years, we have been following these groups of patients, and what you'll see was we then saw the 3-year data where the hazard ratio was maintained between the 2 arms. Next slide. The 4-year estimate again showed that preservation, and the 5-year data now also being presented at the most recent ASH meeting, demonstrating that 5-year outcome, demonstrating again that hazard ratio maintained in terms of showing the benefit for venetoclax over bendamustine rituximab, despite the fact that these patients are off therapy for this duration of time. Next slide. The benefit that we see for this progression-free survival is consistent across all of the groups. And if you look again down these hazard ratios, you'll see that in terms of whether the patients were younger or older, number of prior regimens, the bulk of disease, the presence or absence of deletion 17p, the mutational status, we see very good hazard ratios, and that venetoclax rituximab is favored over bendamustine rituximab in all subgroups, including those high-risk subgroups, which I have highlighted for you here. Next slide. The benefit for progression-free for venetoclax versus BR was sustained throughout those 3 years after end of treatment in patients with T53 mutations and or deletion 17p, as you'll see here. We're seeing a very good outcome in both groups of patients, those with 17p deletions or without, as well as in those with TP53 mutations compared to those who do not have a TP53 mutation here. And again, those hazard ratios looking very consistent. It was also sustained throughout 3 years after the end of treatment, independent of the mutational status. Now, what you will see here is that when these patients come off therapy, those patients who are unmutated will eventually relapse. But if we consistently look at what is the ratio of the outcome for the patients receiving venetoclax rituximab versus bendamustine rituximab, you'll see that we see consistently that even in this higher risk group of patients, the outcome is much better with venetoclax rituximab than with chemotherapy. Next slide. I think one of the most important data that we've seen throughout this study is that we now see a highly statistically significant improvement in overall survival for this group of patients. Now, I'd remind you, of course, that there was a crossover design allowed, and of course, those patients who relapsed with bendamustine rituximab were eligible to receive treatments with novel agents. But despite this, we continue to see an overall survival benefit, which is, if anything, widening over time as we follow these two groups of patients out. And it's this data which drives the guidelines to suggest that there should be no longer any role for using BR when we see a survival advantage for our patients using venetoclax rituximab. Next slide. And that overall survival benefit is, again, I'm going to take you through, has been sustained since the primary analysis. So at a hazard ratio of 0.48 at the 2-year estimate. Next slide. Hazard ratio maintained at the 3-year estimate. Next slide. Maintained again at the 4-year estimate, and maintained again at the 5-year estimate. So no evidence that, despite the fact these patients are off the treatment, that there's any suggestion that there's going to be any difference in the outcome of the survival of these patients. And again, that overall survival benefit is consistent across all of the subgroups we look at, and particularly also in those TP53 mutated groups, where you will see hazard ratio of here of 0.6. So there's no subgroup of patients in whom bendamustine rituximab is favored in terms of overall survival. Next slide. Now, what enables us to stop the therapy and have a fixed duration of therapy is the fact that we see with venetoclax rituximab very high rates of eradication of minimal residual disease. And this is looking at the time point of the end of the chemotherapy. So this shows you here that at the time the patients finished BR, only 13% of these patients were MRD negative versus 62% of the patients receiving venetoclax rituximab. We do see deepening of these MRD responses when patients continue on the therapy. And most of the patients who were MRD positive were able to achieve a low MRD positive rate. That is, that 19.1% that were low MRD positive, when they continue on the venetoclax monotherapy for the next 18 months, converts to a 4.6% rate. Much lower, we see rates of high MRD, particularly compared to what we see with bendamustine rituximab. And it's that difference in minimal residual disease which drives both our ability to see stopping the therapy, but also drives the ability of these patients to have a better outcome. Next slide. Also, if we look at what happens to those patients who are MRD negative at the end of treatment, and we follow those outcomes off venetoclax treatment, here we're looking at the end of treatment, not just at the end of the chemotherapy combination treatment. You'll see again here that 63% of the patients were MRD negative. Those patients who remain progression-free had remained and maintained their MRD negative state. And if we look at the subgroup of patients who become MRD positive, we will see that that MRD positivity rate does increase over time. Next slide. Now, this can be shown here more clearly, where what you see is that the best outcome for our patients was in patients who receive venetoclax rituximab who become MRD negative. And this is looking at their MRD status at the end of the combination treatment in that subgroup of patients who completed 2 years of the venetoclax rituximab. The next best outcome were in those patients who completed the VEN-R who were MRD positive. Then we see that group of patients who have received BR but became MRD negative, remembering, of course, that was a much smaller subgroup. And the worst outcome, of course, at all for those patients receiving BR who are MRD positive. So what you can take from this is clearly is a goal of our therapy to drive our patients towards an MRD negative state. And many studies are ongoing looking at how we can improve upon and even have a higher proportion of our patients becoming MRD negative in this setting. Next slide. And again, if we look at the peripheral blood MRD status at the end of treatment, those patients completing 2 years of VNR, again, we see a better outcome for those patients who are MRD negative compared to those who are MRD positive. The same is true when we look at overall survival. So our better outcome being driven by what happens to whether we are able to eradicate minimum residual disease. So those therapies that drive us into minimum residual disease negative states allow us to stop the therapy and allow us to promise our patients better progression-free and overall survival outcomes. Next slide. So here are the side effect profile associated. In my experience is this drug is very well tolerated. You'll see that neutropenia is a signal which occurs with venetoclax treatment. It occurs most commonly in the period where patients are receiving the combination of venetoclax plus rituximab. The neutropenia that we see associated with venetoclax is not usually associated with an increased risk of infection or febrile neutropenia. The neutropenia responds very well to the use of G-CSF. And the mechanism of action of neutropenia with VEN-R appears different than with chemotherapy, looks more like due because of the expression of BCL2 within later myeloid differentiated cells, which means that these cells respond much more rapidly to G-CSF in terms of recovering the neutropenia. In terms of looking at those adverse events that occurred more frequently, remembering, of course, again, that patients received 6 months of BR versus 2 years of venetoclax rituximab, a very acceptable toxicity profile associated with this class of agents. Next slide. When we looked at what happened at the time of the original reports, what we've been looking for each year, we've seen the updates at ASH, is are there going to be new events that we're going to see that we're going to be later and anything we're going to see. And what we've seen is that there's no new safety concerns that have been reported at the 5-year analysis that we just saw reported at ASH. And of course, we do not see a significant increase in the risks of infection occurring over time. Tumor lysis syndrome, of course, is an adverse event that has to be considered in terms of looking at venetoclax. The current mechanisms that AbbVie have in place to look to mitigate the tumor lysis syndrome have meant that there were very few clinical events, and most of the events that we saw with TLS were associated with laboratory associated TLS only. Next slide. So in summary, we see that the 5-year Murano update demonstrates a sustained progression-free survival with venetoclax rituximab over our best salvage chemotherapy, namely bendamustine rituximab, a median progression-free survival of 53.6 months versus 17 months, respectively, with a hazard ratio of 0.19. We're also now seeing a very clear overall survival benefit for venetoclax rituximab versus bendamustine rituximab, and that this is sustained with further separation of the curves over time, despite the fact that more than 80% of the BR patients were able to go on and receive a novel targeted treatment approach. Now, an important component here is it's not good to be thinking, oh, we should save the best for later on. We see the very best outcomes when we offer our best treatments earlier. And this are my reasons to think that why I would not be offering chemotherapy first and saving venetoclax, rituximab for later. I want to get the best outcome I can with the best class of drugs. We see clearly that the MRD negativity rates, both during and at the end of venetoclax treatment, is associated with longer progression-free survival and overall survival. And in venetoclax rituximab patients who are MRD negative at the end of treatment, the post-treatment 3-year progression-free survival was 61%, and overall survival more than 93%. The clinical response rates for patients who receive salvage therapy of venetoclax or a BTK support early use of venetoclax, I've already said, overall response rates of 72% and 100% respectively for all evaluable patients. And the safety profile of fixed duration venetoclax rituximab is consistent with its known safety profile with no late side effects seen. So with that, I'd like to thank you very much for your attention. Happy if we've still got time to answer any questions that you may have. So thank you.
Thank you, Prof. Gripen, for an elegant talk. So I would like to inform the audience, please type your question. So the first question I have, Dr. Gripen, how do you sequence the new targeted therapy in managing relapse refractory ALL?
Absolutely. So, well, the obvious question, of course, is what therapy did the patient have first? If they've already received a BTK inhibitor, then of course we're going to move at progression to a venetoclax-containing regimen. If a patient has received chemotherapy first, and then they have relapsed and progressed, we have a choice for our patients to either receive a BTK inhibitor or to receive venetoclax rituximab. And my discussion at that point is to say, well, the good news is we have two very good classes of drugs available for treating our patients. One requires continuous therapy, one is fixed duration. And then I'll have a discussion with the patients about what's the goals that they are interested in for their treatment. But, you know, obviously, and not just because I'm talking for Abby this evening, many patients looking to opt to have that treatment-free interval, particularly, and it may be more relevant in your part of the world, where many of the patients, of course, are younger than we see in our group of patients. Having therapy that is a fixed duration allows significant period off therapy, and that's associated, we believe, with an improvement in the overall survival, in the overall quality of life. But we have good options, and we now also have data that tells us if you progress after venetoclax rituximab, you can go back to venetoclax rituximab, or you can also have a good response to a BTK inhibitor. And if you progress on a BTK inhibitor, we move to venetoclax. Little trick we do there is if patients progress on ibrutinib or acalabrutinib, if you stop the drug, the progression can be very rapid, and then you may be seeing a patient's tumor bulk increase as you're starting venetoclax. Our current approach would be to continue the ibrutinib or the acalabrutinib until we have done the ramp up of venetoclax, and to then stop the BTK inhibitor once you have the patient established on the 400 milligram dose. Sorry, long answer.
No, thank you so much. So other question I have is when do you offer bone marrow transplant for relapse CLL?
Yeah, that's a very good question, and the short answer is fewer and fewer occasions right now. So you will have seen in the guidelines that, of course, allogeneic stem cell transplant is still there as an option. It still remains an option which has curative intent. Now, certainly I've published the impact that these agents have had on the frequency in which we're offering stem cell transplants. In my own center, where we used to do 30 to 40 CLL transplants a year, I think we've done one in the last year and probably none last year. That is, of all the patients that I'm seeing, and it's the group of patients usually now who have already received a BTK inhibitor and are now on venetoclax, or who received venetoclax now on a BTK inhibitor who have higher risk features. It's a question of when would we consider doing an allogeneic stem cell transplant. And of course, if the issue is we see with allogeneic stem cell transplants mortality rates in the order of 20% plus, and significant morbidity and mortality from graft versus host disease. So under these circumstances, when I discuss with my patients, as I do, there is this approach there which could cure your disease, and I tell them about the morbidity and mortality associated, what they all invariably say is, well, thank you, I'll continue on the agent I am for a bit longer. The problem we have, of course, is if patients become dual refractory, we may have missed the window of opportunity to do this. But certainly the novel agents have greatly decreased the frequency with which we are offering allogeneic stem cell transplant.
Thank you. So another question I have is regarding the T53. There are 9 different isoforms. Each one plays a different role. How specific these drugs against these isoforms of TP53?
Yeah, it's a very good question. And of course, we know very little about the potential impact of the mutations, the different types which occur. Now, what they all have in common is pretty much a loss of function. And there's not a great deal of data out there about the different isoforms being associated with differential responses to these types of agents. What we do see is that both classes of novel agents, that is the BTK inhibitors and venetoclax combinations, are largely able to overcome the abnormalities seen with TP53. Now, as you've seen here, that group of patients still potentially are going to have a higher incidence of relapse, but there's no data that I'm aware of differential isoforms contributing towards failure of either of the classes of novel agents.
Thank you. So the last question we'll have is, how does the venetoclax refractory phenotype looks like from your experience, especially the PFS curve indicating a potential increase in this phenotype?
Yeah, so of course it's only a matter. So what I will say, of course, is what we've seen. Let me answer your question slightly the opposite way around. What we've seen is that as these patients progress, there's a big difference between progressing off venetoclax than there is when we see patients progressing on BTK inhibitors. And that we are seeing that many of the patients who relapse after venetoclax rituximab can be retreated with venetoclax rituximab rather than moving class of agents at the time that they progress. So although the progression-free survival curve is falling, not many of these patients are truly venetoclax refractory. Obviously, as we get more experience, we are going to see venetoclax refractoriness occur, and we have seen already published from the Melbourne group mechanisms whereby this occurs as mutations occur at the BCL2 binding site. But what we also saw at the 5-year follow-up data was, of course, we saw patients who are now relapsing potentially 3 years off therapy, and these patients can often be retreated with venetoclax. Now, why do I think that's important? We're looking at trying to treat our CLL patients over a very long period of time. I like to try to use up the whole activity of a class of agents before I move to someone else. So just because somebody has progressed on, after receiving venetoclax rituximab, doesn't mean to say I have to now move to a BTK inhibitor. I could potentially get further benefit for my patients with venetoclax treatment, and then maintain the BTK inhibitor to be used in the next line of treatment again. And I'm kind of thinking about this like playing chess, of thinking not just about this move, but what's the moves which are going to occur later. And in that way, again, what I'm trying to do is put off having to offer a stem cell transplant for our patients for as long as possible.
Thank you, Prof. Gribben. By this, we will conclude this talk. I would like to thank Professor Gribben as well as all the speakers today. Special thanks to the administrator as well as the technical team for the great work. And special thanks to the 4,500 attendees who have been staying with us till now. Thank you all, and we'll see you tomorrow at 3 p.m. KSA time for the next day. Thank you.
Thank you very much for your attention. Thank you for inviting me.